I'm really glad that you all are here. My name is Amy Stiffarm. I'm originally from Fort Belknap. Um, I'll get a little bit more into my introduction on the next slide, but why um, you all are hearing from me today is because of our partnership with DPHHS and the Meadowlark initiative. So I understand that you are one of the newest sites for the Meadowlark initiative. And at I work at Healthy Mothers, Healthy Babies, Montana. Um, we're a statewide nonprofit, and we do kind of systematic level, programmatic level support to many, many different organizations and agencies across the state of Montana that are providing direct service to um, to families. And so while we're not doing direct service, we're more of like supporting the people and programs that are. I'm the director of Native American Initiative, so my focus is tribal communities and urban Indian organizations and people that are serving those folks. So um, part of that is me being available to you all, providing this training um, to you all. So just grateful that you guys have had such an interest in it and for showing up. Um, this is something that I've been able to provide to many different labor and delivery units across the state, to different universities, nursing students, um, medical students. So this is something that we're very proud of at HMHB, and mostly very proud of the providers and people who have shown an interest in wanting to better understand caring, how they can better care for indigenous families in Montana. Let's see here. Just to kind of give you some of my background, like I mentioned before, I'm from Fort Belknap. I'm a Awnee, so White Clay or Grovant from the Fort Belknap Indian community. That's where I'm enrolled. I'm also a descendant of the Chippewa Cree and Blackfeet tribes. Um, and I went to school in Harlem, so just right down the road. And when I graduated, I didn't realize how important it would be and how impactful and how lucky I was to attend a tribal college. So, fellow Salish Kootenai College alum with Carla there. Uh, so cool to be virtually with you in this space. Um, when I was there, I received my 4-year degree, and then I went on for my master's in public health at University of Montana. And that was when I had my children, and I became really passionate about maternal health for Indigenous communities. At that time, I was very interested in lactation and in learning about those inequities that our communities face when we're, number one, super limited with support. At that time, when I had my daughter, I lived in Polson. So it felt super urban because there was like a Walmart. And when I needed help with lactation, I was able to call the health department, and somebody came right up to my apartment within 2 hours. And from there, I was gold. Um, Meanwhile, my cousin also just had a baby, and this was her third baby, and she had breastfed all of her children, and she was having issues. And so that time in Fort Belknap, there was one CLC for the entire reservation, and they were the WIC person. And so their schedule was jam-packed. she needed extra support. So she was driving from Hayes, which is the southern part of our reservation, all the way to Great Falls. And that did not feel right. And it was very different from my experience. So I started investigating that. I came across the work of Cami Goldhammer. Um, she's in this picture here. She is, let me see, get my fun laser pointer. Right here in the picture, this is Cami Goldhammer. She is Dakota from, she lives in King County, so Seattle area in Washington. And now she's the founder and director of Hummingbird Indigenous Family Services, where they provide home visiting and doula services to the urban native population there. But her work really started in lactation, and it was her work that when I was reading these like academic literature and peer-reviewed papers about low breastfeeding rates among tribal communities, nobody was talking about why. And it wasn't until I came across her work and she was pointing out the impacts of boarding school and how those impact that disrupted traditional knowledge translation from one generation to the next, and a contemporary impact that we are seeing is lower lactation rates. So that was the first time where I saw someone linking the why and where it made like, oh, well, that makes sense. Well, I had two babies and I, was like, school was the last thing from my mind after finishing a master's degree with two little ones. And the Indigenous Health program, PhD program in Indigenous Health at the University of North Dakota was just created. And I took that opportunity to go back to school, and I actually studied perinatal mental health. And that was from my experience with my second daughter in having depression. That was diagnosed in the postpartum, but knowing what I know now, definitely was going on during pregnancy, but I didn't have the language. And so I really wanted to understand it more. And it was the same scenario there. There were higher rates of mental health complications in pregnancy among American Indian women and birthing people, but nobody was talking about the why, even though trauma was linked. We know trauma increases the risk for mental health complications, but nobody in those papers was talking about historical trauma and the impacts of like boarding schools and all of these other things like Cami did for lactation. So in doing those studies and doing that work and starting to work with Healthy Mothers, Healthy Babies, the need for education and training for providers really became apparent, and not just from the patient side of like, oh, I wish people knew this about us, but also from the providers themselves that saying, hey, we want a way to learn. I know that there are really deep systematic issues when it comes to education and ways to learn more about Indigenous people. So this toolkit came from my dissertation work, and it's really a place to start. So this is offered for free on our website. You can download it. There's a lot more information in there. And I'm able to provide these trainings to kind of talk about some of these things and discuss it and just I think I can't cover everything, but within the next two, I'll be able to touch on some things and kind of give you a little bit better idea on working with Indigenous communities. The first part one that we're doing today, I'm really gonna only talk about kind of getting up to the federal Indian policies, and we'll stop there, which is step one, as I'll show you here in a second. And then next time, that's when we'll go into more of the kind of comparing or being able to understand the differences in culture and kind of look at it as not so much as a barrier, but uh, just understanding that it's different. And then we'll go into some of those skills and communication differences that some of you probably already experienced. Um, so that's my positionality. That's why I come to do this work. That's why you're hearing from me. And yeah, but again, thank you all for being here. So like I said, this is what we're going to cover. What is cultural safety? It's kind of a new-ish term. We'll talk a little bit about some terminology, and then we're going to get to the historical context part today. So what is cultural safety? In my schooling, I was assigned a paper, and it was about cultural safety and why they were urging for this terminology versus competency. And the main issue that the authors had in that paper was that cultural competency kind of gave this false idea that one can become competent in another person's culture. So that in itself is kind of problematic when we think about it. And that's really what was offered a lot, is just these cultural competency training. You could see from this definition kind of what really that's about, is like trying to bring people awareness, help them be more sensitive in their behavior and their attitude when they're working with different populations. But again, it's like, okay, well, now I'm competent and I'm ready, checking this box. Whereas cultural safety, I feel like all of these other trainings that we've been having, this awareness, this humility, it really combines them all. So with cultural safety, we're building that awareness of these power relationships that come from these like cultural differences. And we're not just stopping there at awareness, we're taking it further. We're taking action by addressing those power relationships. And we do that by reflecting on our beliefs, reflecting on our education, and how we do what we do, why we do what we do. And then it gives the power back to the patient by allowing them to determine whether they felt safe or not in that clinical encounter. So to shift away from a more healthcare definition to kind of like, I guess, social work, or I don't know, more holistic definition, is really, it's a concept where we can create an environment where people feel safe, they feel respected, and their identities and experiences are not challenged or denied. And I think that's something that happens a lot within Western systems. I mean, for example, the fact that our history and our presence in general, our existence, is not very well documented in history books. So that erasure, but also when we experience things like racism or, have negative stereotypes, a lot of times those experiences are challenged or denied. And at a bigger scale, things like boarding schools, forced sterilization, things that have happened to our ancestors and in our families have been continuously denied or challenged up until really recently. So even just being able to acknowledge that, hey, I learned about this stuff and this stuff is real, and I can see how it is impacting current health status, that's going to make a big difference. And this is relevant in the healthcare setting, but also in the workplace and all the way back to education, where we're really looking at those power imbalances and what can we do about them? Why do they exist in the first place? So my background is in maternal health, and I work at Healthy Mothers, Healthy Babies. And so naturally, this was created for people who are working with families and people in the perinatal period. But I've had so many other people with range of different backgrounds. I've had people who like work at houseless shelters, and just so many different people, faculty and staff, take this, and it's relevant kind of across the board. It's just that most of the examples that I give and talk about will be related to maternal health. So why is this worth looking at? Like, why do we have to, um, what kind of, where are we starting from? What are we seeing right now? Um, the literature on uh, mental health, specifically for Native women and birthing people, isn't like, it's pretty sparse. Um, and it's not great. There's not a lot of Indigenous representation in the authorship or even community-based research. So it's a lot of like kind of population looking at the numbers. And like I said, a lot of the literature was, first of all, super focused on substance use disorder when looking at Native populations. And then further, wasn't talking about why, wasn't saying like what has happened, what's the history here, and why are we seeing what's a what led us to here? Where's the trauma background? So from the literature that's out there, it's really like kind of obviously based on different communities. So there's a kind of a big range from 14% to almost 30%, which is still higher rates of postpartum depression than the general population. My data isn't perfect, or I take issue with a lot of different data. I really think that if we want to know exact numbers, it really has to be community-based work and led by Indigenous people, and building a relationship and asking questions so people can feel answer correctly or honestly and truthfully. But at the same time, we just know that it's not great. From Maternal Mortality Review Committee data, we were an author trust was able to take that data from the CDC and show that of the deaths from Indigenous birthing people, mental health conditions were the most common at just over 30%. They were the most common underlying cause of pregnancy-related death. And that we got a lot of good data from that. And what was really interesting about that data is when the CDC first reported it, they didn't have anything specific to Indigenous people at all, to American Indian population or anything. And so Trust was able to take this and do some, like they call it like power, like they give numbers different powers and be able to compute it. So the data can definitely be improved, but what we do know is that it is not good when we're looking at the health and well-being of our Native women and birthing people. Montana specific data that we have shows that there is, yes, a higher rate of postpartum depression. Again, is probably not super accurate. But based on 30,000 hospital births, we saw that American Indian women and birthing people had 3 times greater risk of experiencing severe maternal morbidity. And also we see that people aren't, Native women and birthing people aren't accessing prenatal care like the general population are. So compared to white women and birthing people, only 50%, like less than 50%, less than half are accessing care in the first trimester compared to almost 100% for everybody else. So that's important. And it's really, we need to really think about that and think about how we talk about that. A lot of times it's like, oh, well, Native women aren't compliant. I've literally heard people say that before. But hopefully after this presentation, you'll kind of get a better understanding of like, okay, well, why? What are the reasons why people aren't coming to their appointments? And we know this is deeply impacted by the rurality of the state. From that CDC data I was talking about, we saw that all of the deaths by the committee were deemed preventable. So with the CDC data, Montana was actually a part of that. Montana participated in that, or, that data was used. So just recently we came out with not we, but the state um, had a MMRC findings of its own. So that report is available online. You can find it. I could put it in an email too. So Montana specifically, almost 30% of pregnancy-associated deaths were represented by American Indian Alaska Native people. And what's really interesting here is when we're looking at when that happened, it's after 40 days postpartum. It's in that first year, but it's not during birth. It's not prenatally, it's later on. So that's really important when we're thinking, where can we help? And then here in Montana, 45% of the deaths were caused by mental health or substance use disorder. So that's, or suicide or homicide. So those are some pretty bleak statistics. But that's where we're at right now. And again, every one of the deaths were deemed preventable. It's a really, really good report as far as being able to say, this is what they're recommending. They're recommending care coordination. And that's really important for you all as you're starting a Meadowlark program. And I heard somebody come off of mute. Is there a question? I also can't see the chat. So if there's something, let me see. Oh, is that Aaron? Aaron's back on. There's two Aarons. Okay, I'm going to mute this one. I won't kick you out, but just in case. That's my worst.
Yeah, just so you know why there's two Aarons. There's the meeting link was forwarded to a couple people, and they click on it, it just defaults to that. So.
Oh, okay.
Aaron's actually here in the conference. Yeah.
Hello. Hi, Aaron. Okay, yeah, I see it now. There's a whole bunch of you. All right, well, make sure not to kick you out. I'm just muting you guys in case. That's my worst fear, is like being off mute, thinking I'm on mute and being off mute and like taking a phone call or something. So I mentioned rurality, and like it's like you guys are in Fort Peck, like you guys know rurality, right? So just to give so everybody understands like how far we have to travel to give birth in Montana. So just showing the stars are the areas where people deliver babies, and this map is from the Office of Public Instruction, Indian Education for All. I actually use a lot of their content, and they're cited throughout my toolkit in this presentation. But this is just to show, someone in Fort Belknap, they're on the south part of the res, and they're delivering in Havre. This is how far they have to travel. And the study by this researcher at Montana State University found that Indigenous women and birthing people have to travel 24.2 miles farther per appointment for perinatal health care. And we're 20 times more likely to give birth at a hospital without obstetric services. So when we're talking about utilizing prenatal care in the first trimester, it's like, okay, well, yeah, like there are these definite barriers. The Indian Health Service in the Blackfeet Res, that's the only Indian Health Service that is currently delivering babies. And I know Fort Peck and Flathead Reservation both have hospitals within the reservation boundaries, but they're not native led, or the tribe isn't running those organizations. So still within their reservation boundaries, but having to be in a place that isn't like designed for them in a sense. So that rurality piece is key. And again, when we're talking about cultural safety, we're looking at these power dynamics. Now it's really awesome to see the work that's been done on the social determinants of health and helping healthcare providers and even like families be more aware of their determinants of health. And I know there's a lot of screening and whatnot that's been taking place. So that's been just cool to see. And we know that's about power, right? We're we have this understanding now that there are things that people have no control over and it's impacting their health. Um, there are authors that outline social determinants of health and that are unique to Indigenous communities. So mostly that's like colonization, racism. At the intermediate level, it's like accessing facilities that were designed for us or that we access where people don't look like us, that people don't understand us. Um, and then of course, like on the positive side, there's also that cultural continuity and how we know that culture is a protective factor for many mental health complications and other health complications. And so having that access to culture is also going to affect our health in a positive way. And then at the individual level, that health behavior, do we trust our physician? Are we comfortable in that clinic? And so are we going to actually go? Things like that are unique to Indigenous people. So here's the different steps to cultural safety. Looking at you know, those determinants of health that are unique to Indigenous people. When we're talking about colonization, we're actually talking about settler colonialism. And I bring that up now because this cultural safety training, I was able to learn about cultural safety trainings that came from Australia. And this work was actually first created in New Zealand by Maori nurses. And it was they created this for non-Aboriginal people or nurses who were taking care of Aboriginal patients. And in Australia, what I came across in this work in Australia was for non-Aboriginal nurses taking care of Aboriginal cancer patients. And while we're the United States, like what does that have to do with anything? Well, we've both experienced settler colonialism. So here, Canada, New Zealand, Australia, we have experienced settler colonialism, where like regular colonialism, that's when someone would come, they'd set up a colony, and they would extract resources like, diamonds or whatnot, and then they would take those and then they would leave. Well, with settler colonialism, the land is the resource. And so we'll talk about this in federal Indian policy, but in order to settle on that land, people have to be removed. And so where settler colonialism happened, you see a lot of the same, very, very similar health impacts with chronic disease and these just inequitable conditions of health. So that's how it that's why this is so relevant to here, just kind of making it really specific to Montana, but also instead of focusing on cancer, focusing on the perinatal experience. So this is what the whole thing covers. This first day, we're just going to do step 1. And then the next time we'll go over step 2 and 3. So when we're looking at step 1, we're really having that cultural consciousness. So we're gaining that awareness of the constructs of our own culture, and then kind of how that relates to the culture of the groups we're serving, in this case, Indigenous communities. And so first thing is like learning about the people that you serve. How do you do that? I always like preach and love tribal colleges. Of course, I'm a little biased, but they're just such a beautiful act of resistance by Native people. We'll talk about this in federal Indian policy section 2, but for example, boarding schools, we used to have to leave to obtain, like forced to leave, be taken away. And then after that, leave to go get an education. But now with tribal colleges, we're able to stay in our communities, stay with our people, amongst our culture, amongst our language, and learn not just Western academics, but also our language. And so it's just this beautiful cultural revitalization. And the coolest thing is that they're not just for Native people. Other people can totally go to a tribal college and take a class, and I really recommend that. Even if you're looking for local resources, maybe it's a speaker, maybe it's a book. Your tribal college is a really, really good place to start, and every reservation in Montana has one. Um, so learning about the people you serve, there's a lot of different terminology. I've probably used them all because I just use them interchangeably as far as Indigenous and Native um, and Indian. So we'll go into that. You guys are on a reservation for the most part, and there are other Meadowlark sites watching this. So it's like, what reservations are closest to you? What tribes are the people who come to see you? What tribes are they from? And how do they identify? So Indigenous was actually first officially defined in the 80s in what was called the Cabo study. But basically Indigenous is a term that describes people who are the original inhabitants of that land. So when we're talking about the United States, we're talking about the tribal nations here. Um, so that's kind of when we do land acknowledgements, or when you have a land acknowledgement, that's acknowledging that there were people here in this space, and they took care of this land. And in order for this town, this building to be here, those people had to be removed and the land was stolen. And so if you guys are on you're I think of Fort Peck and CSKT, it's a little bit different because there are it's kind of a what we would call like a checkerboard situation. So it's really interesting to go back and kind of learn that history of the place that you're on. So back to terminology, American Indian. There's a lot of my policy friends that are like, use American Indian because that's the term that is in the federal Indian policies. That's that's the language that's the treaty language, and we have to uphold the treaties. But it's controversial, and a lot of people don't like it because we know that Christopher Columbus thought he landed in India, and that's why he called the indigenous people here Indians. And we don't want to be named or referred to as something that Christopher Columbus named, because we don't we we know now all of the different terrible things he did, plus colonization that came from him coming here had devastating impacts on the indigenous people. Native American is also commonly used, but again, American, people take issue with that word because, number one, like, indigenous people were here far before America was even a thing, but also America is also named after an Italian explorer. And it might be news to some, but a lot of Native people don't hold the same regard, to say the least, for explorers in general. That has to do with, again, noting the devastation that happened, the violence that happened from exploration, but also even today when we talk about explorers, and it kind of it it it's really easy to erase indigenous people when we're only kind of celebrating these explorers. So it happens a lot with Lewis and Clark. I live in Helena, and it's like Lewis and Clark everything all the time. And so just being careful, like, we're not saying, Lewis and Clark discovered this area. They came here, they explored it, and there were already people here. And so just important to think about those things. Well, it's like, all right, what do we say though, right? It can, like, all of it isn't the best, right? First of all, however a Native or Indigenous person identifies, like, that's how they identify. My dad, when I told him I got into the Indigenous health program, he said, Indigenous, like, what's Indigenous? Like, I'm an Indian. So yes, you are an Indian, I'm an Indian too. And we say it like Indian, right? Like with our accent and all that. But that's how he identifies. And I say that too. Like, don't ever correct anybody about, aren't, well, you're supposed to say Indigenous now. Um, so meeting with some doctors, they were kind of like, all right, you got to give us something though. Like what is the most appropriate? So we kind of talked it out, and they did feel uncomfortable saying Indian. Um, they felt better saying like Native. So that's kind of what they decided, like, oh, there's a special group on Tuesdays for the Native community, you should join that. And so they're kind of like practicing it. But if you're working with a special program or you're working with a tribe and they have certain language that they use that. So follow the lead of the groups you're working with. But when you're dealing with patients, a lot of times they're just going to want to be called their tribe, like who they are. Like for myself, like I'm from Fort Belknap and I'm Aani. The real important thing to know is that it's different. There are 7 reservations, but we have like 13 different tribes among those. So I think I really get stuck here a lot because being from Fort Belknap, there's 2 different tribes, completely different languages and cultures. And I went to school on the Flathead Reservation, and you know, same thing. The Confederated Salish are the Salish and the Kalispel because they have a similar language. But the Kasanka are Kootenai, and so they're a unique dialect and it's completely different. So there's a lot of misconceptions there. And it's important to understand that about the people. Don't just assume because somebody's from Fort Belknap that they're Nakota or whatnot. Just be able to kind of decipher that. Um, it's really important when we're talking about identity because the example that I give is I'm Aani, and that's how I introduce myself. But when I pull out my tribal identification card, it says on there Grovant. And in French, how that happened was the French fur traders were over, and my ancestors met them, and they tried to tell them that they're Aani, or their sign language for themselves was like the people from the White Clay below the falls, and they were giving this motion. Well, um, the French saw that and they said, "Oh, their motion like big bellies," and so that's what Gros ventre means. It means big belly. And that's actually pretty derogative. And there's a lot of, now it's like kind of teasing or whatever, about, being big bellies or, being overweight really is what people say, about Aani people, that stereotype. And, the elders really didn't like it, people don't like it. And I remember one time getting in trouble by my auntie because I was, saying, I was like, oh, I'm Gros ventre. Oh, you're not Gros ventre, you're White Clay, And so it's like, we'll change it. Well, we can't because, again, going back to the treaties, this is the language that's in the treaties. So this is what it says. But going back to tribal colleges, that's one way that a lot of tribes and tribal nations are reclaiming their own identity. And Fort Belknap, first of all, Belknap was a Secretary of War, so that's what our reservation is named after. And we used to be Fort Belknap Community College, but we changed it to Aani Nakota College. So that's one way to reclaim our identity and who we are. So just know that when you're serving patients, that they may say, oh, well, I'm Nakota, or it might be different. And for a lot of people, it means a lot just to ask them, and like, oh, which tribe are you? And it's just like getting to know them a little bit better and acknowledging like, hey, you're an Indigenous person, and that, that's important here. Important as in, like it's different. This is different, like how we interpret the world around us. The other big thing about terminology is using gender inclusive language. Um, I kind of follow the lead of Cami Goldhammer, who I mentioned earlier. Um, they used to host the Native American Breastfeeding Week, and they changed it to be more inclusive, and they called it Indigenous Milk Medicine Week, recognizing and being descriptive of what breastfeeding does, right? It provides that milk medicine. And Indigenous languages are super descriptive. Um, and so that's kind of what I try to embody when I'm talking about uh, people who give birth. I see them, they're birth givers. Um, I, I I follow that lead, and it really resonates with me because we know that um, from numerous other Indigenous languages. And when I'm talking about, I really don't mean to make it sound like all Indigenous people are the same, but there are different commonalities among certain groups. It's not the same for everybody, but there are a lot of different Indigenous languages um, that have multiple genders within their language. So that dichotomy of boy or girl, that was a worldview that came over with the Europeans. Um, and for most Indigenous worldviews, it's a more fluid, and it's really based. It's describing that person. Two spirit is kind of a newer term that came out of Canada, and that's just recognizing that someone has both a masculine and feminine spirit. And so when we say terms like birth givers or birthing people, we're really talking about that person's sacred ability to bring life into this world. And this is again, like, never assume, like, there's so many different spectrums, because there's not only like multiple tribes within one reservation. There's the urban Indian community, um, and there's also like how different communities were impacted by colonization. So maybe there's a community where they're more they have more of their culture, and are practicing more of their culture. And even among families, like some families were more impacted by boarding schools and whatnot. And so just know that everybody's different, and we can't really assume just because we know one person from there that, there's you guys know, treat people like individuals. So going into it more and kind of thinking about these cultural constructs that are going to affect how Indigenous people interact with the healthcare system. Well, I think of a good example of this is right outside our Indian Health Service in Fort Belknap, there's a sign, and the top is, hospital is English, but below that you have Aani, and that translation, how they would say hospital is where they doctor. For Nakota people, they would say a sick person's house. So kind of going back to what we know about people not accessing or not utilizing um, prenatal care in that first trimester. You know, way back in the day when hospitals and stuff first started coming to the reservation, they had to make a big effort to stop Indigenous midwifery, um, because people weren't coming to the hospital when they were pregnant and to have their baby. But it's like, okay, well, if I'm pregnant and I'm like sacred, right? Like, would I go to a sick person's house? When they say where they doctor, that kind of relates that has to do with traditional medicine and accessing like a traditional healer. Sometimes in ceremony today, you'll hear about people getting doctored. And so that has to do with ceremony, and when something is bad or when someone is sick, you get doctored. And so if you're pregnant, like, do you need to be doctored? And so right away, just from the difference in languages and point of view, there's this conflict between Indigenous perspective and the Western healthcare system. So before you're even getting into the door, there's this this conflict. So going into the historical context, I get to play history teacher. There's kind of this joke among us public health people that if you're going to do anything like Native, Indigenous, public health, you have to be part history teacher because so many people haven't had the opportunity to learn. And I give people a lot of grace because in doing this deep dive, I've learned a lot. Like I've only gotten to learn this stuff because I had the privilege of going to school. There was so much of this stuff that I didn't know. We weren't talking about this stuff. I did have to take a class at SKC, and that really opened my eyes. But we were 99% Native at my school, and we weren't talking about this kind of thing. So I give people a lot of grace, and I want you all to give yourself grace and um, just understand that I'm not going talking about this to like make anybody feel bad. Just recognizing that in order to get to health equity, we're going to have to walk through truth. And so, y'all know how it is on the plains and the harsh winters. And as Indians, we really look up to the buffalo and look to them, and they teach us. And so, what we learn from the buffalo is when a storm comes, they don't run and cower and avoid it. Right? They know that the quickest way to make it through this storm is to put their head down and go through it. Just be strong and walk through it. So that's what I think of when we get to this part of these trainings, and I have to tell people some things that might make them uncomfortable, things that make me uncomfortable. But I have plenty of I've been doing this for years now, so um, it's still it is hard to talk about. It's hard to hear about. So I just want to let you guys all know that I give you lots of grace. So the first part of federal Indian policy is this colonization period. So 1492, Christopher Columbus came over, thought he landed in India, but discovered the New World. And kind of the very first conflict with religion and Indigenous people is that it was actually documents signed by different popes that made it okay for people to come over here and steal land. So it was like, all right, yep, as long as, they're not Christian and they need to be saved. And so whatever means necessary. So they made it okay, basically dehumanized the Indigenous people here so that people wouldn't feel bad, made it okay to steal land. And in order to occupy land where there's already people at, they had to be removed. And in this period, it was how they did that was through violence. So we know by the time things happened here on the West, our ancestors had more information, but on the East Coast, it was really taken by surprise. So that's why if you're from the East Coast or, you don't know a lot of the tribes there. There's not people, there's not as many Native people there. And that's because of the violence that their tribes experienced, coming up on Thanksgiving, understanding that where the real story of Thanksgiving came was after a massacre of a Indigenous tribe. And then it was celebrated by the United States. And so really kind of looking at how we tend to water down that history and making an effort to better understand that, especially if we're serving Native people. But now we know here in Montana that we have the 5th highest missing and murdered girls and women rate in the country. And scholars and people working in this field point to the colonial colonization era as the beginning of this epidemic. And so we know, and my kids are young. My kids are 11 and 9. And geez, it was probably about 4 years ago or so that I had to have the talk with them where I told them, hey, we're about to go into Walmart, so you guys have to stay close to me, and explain to them that we are more likely that something bad is going to happen to us just because of who we are. And it's sucked. It's like I was, like it wasn't didn't feel awesome to tell my kids that, especially when they're so young, but that's our reality. And I wanted them to know that they have to be safe. And that's something we talk about. So when we're talking about leaving our communities and going to a facility for our prenatal or for our 6 weeks checkup, there it's scary. There are towns that I don't go in, I don't stop in, um, towns that, it's where it's not safe to be a Native person. And that's just still how it is in a lot of places. Of course, it's not everybody. Um, but that is when people are aware and they know of this, it's in the back of your mind. And so things like going to the hospital or going to the grocery store, these are things that we're thinking of. So when we're talking about people going to appointments and, we need to be looking at the whole picture because they're not just coming to your clinic. If I live in Fort Belknap and I'm going to Havre, I'm going to need to stop and get gas. I'm going to get something to eat, hopefully. um, if I'm going there and there's a Walmart compared to our grocery store, I'm probably going to stock up on supplies. And so we're not usually just experiencing that your facility where it's the whole town. And so um, it it's a big deal to have to leave your community. Um, the next era is this treaty making and removal. So it was kind of to end the violence. This map again from OPI. You're looking at these pastel areas. This is the area that was originally promised to these tribes. Like, hey, you guys are able to be here and access all of this area, but slowly and slowly, um, almost 400 different treaties were ratified so that we're eventually put on these little teeny tiny reservations. And I think what people don't understand about this period is like you couldn't leave. Like it's not just that you were put on, you could only live in this little area now. You couldn't leave. You had to have special permission by the Bureau of Indian Affairs, and they had to deem you competent. And so, if you're speaking your native language and you didn't know English, then they weren't gonna, they was, you were a prisoner. Um, so when I look at that time, I think of that time and I'm thinking of maternal health. I think of um, people not having access to certain sites. There are a lot of different sites that were sacred that aren't within our reservation boundaries. I think about access to certain foods, to a healthy diet, access to certain medicines that, all of that was taken. And I think that's important too to note when we're talking about um, this land and it's not so much about owning. It's not like, oh, these people owned this land. They had a relationship with that. They had a reciprocal relationship with that land. They took care of the land and the land took care of them. And so it's um, more of a way of life than at like an ownership point of view. Um, so now that people are on reservations, we're looking at this period of assimilation. And this was when, so at first, when it was really violent and there was like land stealing and needing to get rid of people, it happened through genocide. And the Native women and birthing people and children were targeted. There is actually letters from war generals talking specifically about within their strategy going after the women, birthing people and children. One of the common mindsets that I forget the guy's name, which is fine with me. I don't care to like really remember these people. um, but they used to say the only good Indian is a dead Indian. Well, with assimilation, they're ending that violence. They're all on the reservation. Now they want to assimilate Native people to be white people. And so the idea shifts from the only good Indian is a dead Indian to um, the save, kill the Indian, save the man. So that's where we're gonna get into boarding schools. Also, during this period is when traditional medicine was outlawed. So being on a reservation, people were coming together, participating in ceremony, and they saw that that was still keeping people connected and empowering them. And so they wanted to disempower Indigenous people, and so they made it illegal to practice your culture. Um, that came about in the Code of Indian Offenses in 1883. And that went on for 100 years. It wasn't until the 1978 American Indian Religious Freedom Act where we legally able to have ceremonies. So during this period, that's when uh, people would get jailed. There would be violence. There are actually quite a few massacres that occurred because of people doing ceremonies when it was banned. Um, and really all because it was different, because people didn't understand it, right? It wasn't their way, so it wasn't the right way. Um, and so I think that's something to really think about, especially knowing what we know now about the importance of culture for improving health and for being a protective factor for so many, um, negative health uh, issues. Culture, you're not allowed to do it in this period. So now getting back to boarding schools, um, this was a very, very, very violent time. So this is kind of how Cami Goldhammer first explained it when looking at lactation rates. And she said, you know, if you're taking the children, we're talking kids as young as 3 years old, forcibly removed from their families, from their community, and sent to boarding school. Now, sometimes these were right down the road. Sometimes, more often than not, they were far away. Especially if they were closer and kids would run away, then they would get sent further. Um, but you're removing those kids, so they're gone in that community. They're not able to see how the community takes care of someone who's pregnant, how they take care of someone who's in the postpartum period. They're not able to see how they're feeding that baby, right? So they don't see any of that because they're away at these boarding schools. Not only that, I think it's important to really think about um, the devastation that occurred to those communities when those kids were gone. The United States viewed their position with Native people as at war, right? Like we're being, even this first boarding school um, was ran by a former um, a former U.S. general, and so um, they this the United States government, they knew that by taking the children that they could get the people within on the reservations to be more obedient and to obey, knowing that their children were hostage. Um, so these were government funded, often ran by different churches, and um, it if you didn't send your kids, you were at risk of losing your rations, or jailed, or violence. Um, Different violent things could happen. There are lots of different stories and houses and stuff that you hear about from different Native families where there was hiding spots for kids whenever an Indian agent car would pull up, or then the kids would know to hide. And so some families were able to avoid it, but their children lived in hiding, and which is also not like the best childhood to have. So, so many kids in these schools. Um, by 1926, 83% of school-age children were in these boarding schools. Um, Removing all of those kids had just devastating impacts to the community. This is when you start, because you're not able, the healing that you would normally access from ceremony. That's outlawed. So you don't have your coping mechanisms. So what do you have? There's unhealthy coping mechanisms that come into play here when we're looking at things like substance use disorder. Alcohol was introduced around, was around then. And so that was how people coped. And so some of the cycles that we see, um, um, this is where it started for a lot of families. Not only, and then that's just not even the worst of it, right? That's kind of the local impacts. At the boarding schools, it was horrific. There's full reports on the conditions there, like how dirty they were. They were starved. The violence that happened there. They weren't allowed to speak their native language. And so you have to really think about that. These are native kids. That's their language. They speak their native language. They're shipped off to these schools and they can't talk to one another. They can't comfort one another. They can't, oh, I see an older kid there. Like, they can't tell them what's going on. They can't prepare them or help them with the rules because they can't understand English. They're not allowed to speak native. So it's just this really, I think about that sometimes and it's just so hard to imagine. Not only that, the violence, the sexual violence, there are, this is kind of one of those experiences where things were, experiences that was denied or kind of challenged or maybe written off before. But in, was it 2020 or 2021, a mass grave was discovered outside of a old boarding school in Kamloops, British Columbia. And that really raised a lot of this awareness, got a lot of media attention. So things that, in our communities that we were kind of talking about, a lot of families wouldn't talk about it because it was so traumatic. People started talking about it. And so now we know more. And it's more, I guess, like validated because of this investigation looking into mass graves. So in 2021, Secretary Deb Haaland, she announced the Federal Indian Boarding School Initiative. Deborah Parker, who's Tulalip, she runs the Native American Boarding School Healing Coalition. And this is a really great podcast on all my relations. And it talks about working on this initiative and getting to the point where finally, was it just last year, we get an official apology from the United States. This work has been happening in Canada a lot longer because of their recognition of it. They have a truth and reconciliation policy, and so their government has been investigating it and kind of like number one, acknowledging and apologizing for what has happened in a formal way. So for Biden to have that from the United States, an acknowledgement and an apology, that means something. It's that first step, of people recognizing like, oh yeah, this actually really happened. And these have real contemporary impacts to this day, right? I'm sure we see it. I see it all the time. I experience it. So for here in Montana, we had 18 different boarding school sites. So when after that with Kamloops and it got more media attention, on one of my scholarship applications when I was in my PhD program, it asked if I was a survivor or if I was a descendant of a survivor of boarding school, if my family was impacted. So I'm like, oh yeah, well, my grandpa went to boarding school. And so I called my dad just to be sure. My mom and dad were on the phone, and just a chill Sunday, I'm calling them and saying, hey, I'm on like literally the last question of the scholarship application. I just wanted to make sure, like, Grandpa Pete went to the boarding school in Fort Belknap, right? And Haskell, and which is in Kansas, and that's now a tribal college, but before it was a high school. Um, and he said, yeah, and your grandma. So what they met at the boarding school in Fort Belknap. So my grandma Ruby, Chief goes out from Rocky Boy, who was at that boarding school with my grandpa Pete. Um, and she went there. And then my mom chimes in. Um, my mom chimes in and she said, yeah, and your grandma went to boarding school in Cutbank, and I did for a little bit too. And, I was older, I wasn't like a traditional college student. I had taken a break, and, I'm the youngest of my family. My older brother is in his 40s and I'm in my late 30s. And I'm just finding out that my mom went to boarding school, and I'm just like shocked. And, my older brother did know, but my middle brother didn't. And so we were like, what the heck? So just kind of sitting with that. And then another story during that conversation came up where we knew about my grandpa going to boarding school because it was kind of this, he had a really different story. He went after, um, he continued on and was able to graduate high school by going to Haskell. And so it was kind of this like positive thing because after that, he served in World War II, and he was actually at Normandy, and he got his knee shot off and received a Purple Heart for that. Well, that was around the same time that the GI Bill came to be. So he used that funding and went and got his 4-year degree, bachelor's degree, in 1949 at Montana State College. And so that's how I knew about my grandpa, because I knew that he did that stuff. I had no idea that my mom had went to boarding school. But my dad said that because he went to Haskell after it became a junior college. So it used to be a high school, then it became a junior college. Now it's a tribal college. So when my dad graduated high school, he went to junior college there, and he played sports there, and they were running. They had to run through the school, through campus, when he first got there to, as part of their training. And they came across this place, and it had all these little white markers. And my dad, was thinking to himself, my dad never mentioned this. And so the next time he calls back, he said, hey, I came across this spot. And my grandpa, all he said was, oh yeah, those are the ones who didn't make it home. And my dad, was thinking, what? Like, well, who took care of them? Because for Indigenous people, like our tribes, we all have very different, but really special protocols for caring for people who are passing on to the other side, or who have passed on. So, there's different, different ceremonies, different songs, different things that happen to honor somebody, the protocol for when someone passes away, and what to do. Like, for example, some people cut their hair in mourning. There's different ways. Yeah, it's just different. And if you work with tribal communities enough, like, you will most likely get invited to a wake or a funeral first for one of your patients, maybe. But my dad said, well, who took care of them? And my grandpa said, we did. So, thinking back, he was a high schooler at that time. And when people weren't, when people were dying, whether that be sickness or from violence, the kids were the ones who had to take care of one another and trying to give them, somewhat of a proper burial. Well, now, one of the laws, I didn't cover it in here, but it's called the Native American graves. Well, just escaped me. But NAGPRA, Graves and Reparations Act? NAGPRA. Anyway. Now, a lot of these places, remains have been, basically, anthropologists, schools, they have collections of Native ancestors that were dug up and used for studying. And so I don't know if you guys are aware of, I think it was just last spring, in Fort Belknap, maybe it's 2 springs ago. Uh, at the Carlisle Indian School in Pennsylvania, they were able to they discovered some 3 kids from Fort Belknap that died over there, and so because of NAGPRA, the federal government says, okay, there's no more like you can't be robbing graves and you're not going to be putting them in museums. Like you have to give back these ancestral remains and anything else, that usually there's things buried with them. So anyways, our leaders went out and they got them and they drove back to Fort Belknap. And that was a really big deal because we were able, our people, our tribal, our spiritual leaders, excuse me, were able to give them proper burials, and in protocol and have ceremony and all of that. And it was pretty cool because I know they drove through like Fort Peck area, and there were a lot of even non-native schools that they all like in different communities that people came out and stood and showed their respect for those kids that were making it home. So that's something too that is happening more and more, with especially thinking of like these mass graves where these children are and finally able to make their way home. Another era is this relocation, termination and relocation. So when you hear of like state recognized tribes and stuff, that's when they were terminating tribes. They were like, okay, you're not actually a tribe anymore. So that was happening. Over 100 tribes were terminated during this time. And also relocation was happening. So this is another way to disrupt Native families. And so this is really where urban Indian populations come from. And the idea is that they're kind of advertising these bright and shiny jobs with money and city where there's better places to live. And so people would go and they would do that. But when they would get there, it wasn't really what they were promised. And for the ones that wanted to come home, there wasn't a way to come home. There was no money. So they were really like put into poverty here going into these cities. Montana actually had relocation towns. So when I think of relocation cities, like there's common ones are like Chicago, Oakland, Seattle, and the beautiful thing and where you see those strengths kind of shining through is even though Indian people were from all over, when they came to these areas and they came together and they were there for one another. And so you see these really large centers now for American Indians in these different areas that came to be because of that. So that happened because of relocation. Cities in Montana were Missoula, Butte, and Glasgow. And so one thing that I learned just a few years ago after my grandmother passed away, I always knew that my mom grew up or went to high school in Missoula, but I didn't realize that my grandmother was part of the relocation program. So she lived in East Glacier, Blackfeet, and she signed up for a VOTEC school in Missoula. And so my mom remembers being little and them all loading up and going to Missoula. And when they got there, they didn't have a place to live like they were promised. It wasn't ready. And it's funny because like there's these like little bits of stories. And I remember being in Missoula for like Kiaiopawa, and we drive by this motel, and my mom would start talking about having to clean motel rooms when she was little. And when I was a kid and we stayed somewhere at a hotel or a motel, she was very strict about, being being clean and picking up after yourself. And I remember one time being in trouble because I was being rude, like, oh, the maids will get it. And she really put me in my place there. Well, come to find out, the reason why mom was like that and her experience there was that my grandma had these kids and was in Missoula away from home, didn't have a place to live and didn't have any money to go to school at this Botech school. And she made arrangements with this motel to let them stay there and they would clean the rooms. And so my mom and her siblings cleaned rooms so that they um, had a place to stay. Um, and so that's how, when people got there, they weren't properly kept track of. There's a really good book by Louise Erdrich. It's a fiction book, but it talks about this time period. And this man came and married into this family and convinced his new wife to join the relocation program. Well, they didn't hear from her for a while, and so they tried to find her, and that the relocation program didn't keep track of them, didn't know, where she was or anything. So they went and to go look for her, and she had been she had been trafficked. And that book and what people today point to this relocation as the beginning of the human trafficking epidemic, or well, not really the beginning because there's slavery and all of that, but um, that was common. And I was just in a training and we were talking about this because and I hadn't even thought about it, but their special Montana tribes have been recently, just since COVID and whatnot, being targeted to go to these treatment centers, and so that these false treatment centers were, claiming insurance and stuff off of them and getting reimbursed by different Medicaids and whatnot. And those people too were being rounded up and brought down like on buses down to the south, and like some of them being trafficked, some of them they were there for treatment and they were being drugged. And so things like this, it's kind of eerie when you think about how some of this stuff is still happening. Really important to maternal health, kind of going back to relocation. You get there, your family just moved, and then you get pregnant. For most people that moved away, that was their first experience with the healthcare system. For many, many Native families, people's first experience with the Western healthcare system happened during boarding school. So when all that traumatic things was happening, so especially with elders and whatnot, there's a lot of distrust over the Western healthcare system. If you're away from home and you become pregnant, they're not able to utilize like traditional or communal extended family support systems. Didn't have access to those cultural teachings from family or elders. And then being in these cities, they were exposed to discrimination in healthcare, which we know is still experienced today, and we know has really negative impacts on people's health status overall. Some other issues that create a distrustful system are these reproductive injustices that happened in the 1960s and 70s. So one of them really being that, again, we're kind of hearing more and more about is the unjust removal of American Indian children from their families and their communities. So much so that in 1978, the federal government had to pass the Indian Child Welfare Act to protect Indian kids from being removed. So at one point, there was about 80% of American Indian families that lost at least one child to this foster care system. And a lot of it was from, some of it was like good intention, and a lot of it was discrimination and not understanding culture and, you know, for being poor, right? And when really this looking at these social determinants of health and whatnot, this economic status was really forced upon, it put on Indigenous people. And so, while there was only 9% of children in the population, 35% were overrepresented in foster care for the state of Montana. So that was when you're just looking at that and kind of looking at a face value, it could seem like, oh, being, there were people had to remove Native kids. It must be bad to be in Native families. But we know because, we know about, we're learning, right, together how these systems created that to happen. So before ICWA passed in Montana, the rate of Indigenous children placed in foster care was 13 times greater. And what's really important here, what we need to understand is that cultural thing. We know that culture is important and it has an important strength. So that's why we want Native children to have access to that culture and stay within their community. The other injustice that happened here is the forced sterilization of American Indian Alaska Native women and birthing people. So this was like a little tiny study by the government, and it didn't look at very many hospitals at all. But what they found, around like 25% to 50% of Indian women and birthing people were sterilized without their knowledge or with coerced consent. And so that creates so much distrust too. So when we're thinking of people in childbearing age, we need to understand that boarding schools run in their family. We need to understand that someone was probably impacted by ICWA, and that someone in their family was probably sterilized. And so this is not personal. If someone isn't trusting you or coming to your clinic, it's not personal. These are systematic issues. I wanted to point out this podcast called This Land. It's season 2, and it goes into the best deep dive about the Indian Child Welfare Act if you all are interested. Self-determination, this in 1970, Nixon was really a big part of this. And really what self-determination did is it recognized tribal nations as U.S. Or as foreign or sovereign domestic dependent nations. So there's certain tribes have treaty rights, and we go by federal policies and laws, and we don't always have to go by state laws. And so sometimes you kind of see that. But this was where tribes were able to take control over budgets and for instead of having the BIA run certain things, then the tribe runs it. Instead of having Indian Health Service run certain things, the tribe runs it and has control over their budget. And then I also think it's important to know when we're talking about federal Indian policies that it was these are our treaty rights to have access to health care, and it's in this is an act of Congress that made this so. But when we're talking about the Indian Health Service, we have to understand that it's not this bright, shiny healthcare. It's always been underfunded. We are funded less than prisoners in the United States. And it's not like an insurance program. It doesn't follow you. So I think that's something that people, I barely understand how the Indian Health Service and all of that funding and whatnot works. It is a pretty complicated system. But know that tribes are kind of taking over their budget and whatnot and able to address things, what they see needs to be done at a local level. So that was a lot of tough truths to walk through. I know we don't have a lot of time for questions. I'm happy to stay on for a little bit if anybody wants to. I really encourage you guys to have group discussions within your work site. I'm also happy to come back and maybe as a Meadowlark site especially, I can have another chat with you all or have a specialized kind of group discussion, something like that. Usually after people hear this information, they kind of need some time to digest and process. And then again, we'll get more into that strength-based and really understanding that these things, they happen to Indigenous people. It's not Indigenous people. This isn't our culture. This isn't who we are. It's what happened to us. So next time, I really look forward to talking about the strengths within Indigenous culture and how they can, how really looking at those strengths and utilizing those strengths can make a positive impact on our health conditions. So thank you guys. If there's any questions, feel free to let me know.